of management as well as to describe common surgical procedures for a cavus foot. Right. If you look at these pictures on the left side, we see a typical severe cavus foot. The elements which we need to be cognizant of when we are looking at such a patient are the equinus deformity, which is at the level of the ankle. The cavus is the first ray, dropped first ray, which is at the torso metatarsal region. So there's an acute sharp curve in the middle of the foot over the medial arch. So there is an exaggerated medial arch which is very prominent. Here we can phalangeal joints are hyperextended and some of the toes can be clawed, which can be probably better appreciated here. So it's hyperextension and then flexion of the IP joint evident here. Many of these patients end up having callosities form because of the footwear, not only over the surface, over the dorsal surface, but also the plantar surface.
Hello.
Big toe, metatarsophalangeal joint, as well as the lateral toe, and the lateral border of the foot could well have callosities formed. When we look at the patient standing from behind, the deformity becomes even more clear. Here we see the hind foot in a varus position on both sides, more severe on the right side. Typically, the hind foot is supposed to be about 10 degrees of valgus, but in these cases, the hind foot ends up being in a varus position. So these are the things that the patients present with. You can imagine the kind of biomechanical abnormalities this kind of a position of the foot results in. So the patient, instead of walking with a balanced weight distribution over the plantar surface, they are walking more on the lateral border of the foot, and the heel is off. And if we connect the center of the knee, which we uh, it is not passing through the center of the heel. The heel is much too medial to the center of the weight-bearing axis.
So guys, if you mind just muting yourself, yeah?
कितने पेंट्स हैं इनके पास?
So 250 ml के दो. एक लग गया, एक पड़ा हुआ है.
आपने क्या लिखा है?
Right. So when we see a patient with a cavus foot and we start examining the patient, one of the things that I usually do right at the outset is to examine for a gastrocnemius contracture, which is something which is very commonly associated with in these patients. And typical equinus deformity at the ankle is usually the result of gastrocnemius contracture instead of a full Achilles tendon contracture. Differentiate the two is to do a silver scale test. With the knee fully extended, we check how much dorsiflexion we can achieve. Typically, in these patients, the foot is either neutral or it is in slight flexion. While when we flex the knee, we are able to achieve at least 20 degrees more dorsiflexion. So that shows us that the gastrocnemius muscle is tight. Now that is important to know because whatever correction we are doing in the forefoot, we do not want the forefoot to remain getting overloaded at the end of our procedure. So if we done osteotomies and tendon transfers in the forefoot, the results would be better if we also redistribute the forces of equinus. So there's no residual equinus left. So that balances the gait. So and must not be left out. Now, when we see a patient from the front, now one of the telltale signs suggesting heel varus deformity is a peekaboo sign. Does any of you among the participants know what is the correct position to do the peek? if you look at these two, we can see the heel in both of them. Peekaboo means that the heel is visible. You're just looking at the patient from the front and you can see the heel. That should not be there. But in which position? If we look at this foot, we can see the heel here. In this foot also, we can see the heel here. But this foot, you can see is slightly externally rotated, isn't it? So if you do externally rotate, you will always be able to see the heel. So the correct way to look at the peekaboo heel is have the foot face forward. This is a better picture for that. You see that the forefoot is facing forward, it's straight towards you. This is straight towards you, the foot. And in that position, if you see the heel, that's a peekaboo. You're not supposed to see that. That is there because of the varus of the heel. It is supposed to be here, behind this part of the foot. All right, so far so good. Once we've confirmed that the patient has a heel varus, that's what it looks like from behind, as I showed you in the previous slide. How do we know that if it is a fixed varus or a flexible one? We need to differentiate that because we need to adjust our procedure according to that. If it is a rigid deformity, then only osteotomies and fusion in the correct. If it is a flexible deformity, then you may not need to fuse the joint. So that the decision depends on the flexibility. Now, what flexibility does it show? The hind foot is connected to the forefoot. So if the forefoot has a cavus deformity, then when the foot falling on the ground, like on this one image on the left, the cavus deformity leads to a tilting of the heel. Now, this is the same patient which is lying prone with the knee flexed 90 degrees. You're looking at the patient's foot and heel. So we can see that the first and it puts weight, then this slope from the first to the fifth toe, MTP joints, is going to become neutral, flat. And that is what is going to tilt the heel into varus. So this is what is happening here. So when we put a block under the heel and the lateral wall of the foot, not under the first ray, and letting the first ray correct to some extent. We may see partial correction, we may see full correction, and that is what we need to note. If we don't see any improvement in the varus, that means that there is fixed heel varus at the subtalar joint. Now, if the subtalar joint has a fixed varus deformity, only a corrective or fusion is going to correct that. This Coleman block test does not tell you about the flexibility of the midfoot. Okay, it's only for the hind foot flexibility, and specifically subtalar joint. So that is something which we need to be wary about. Right. Now these are other pictures. Again, here we see the peekaboo signs here, and if we look at the heel, both heels are in varus, and once we have corrected a Coleman block like this, we see that this varus seems to be corrected to a more neutral position, suggesting a flexible hindfoot varus. X-rays. Now, X-rays in these patients are important for us to identify the apex of the deformity. Why do we need to know the apex of the deformity? Because that is where we want to do the correction. If, for example, this is the apex, do an osteotomy, corrective osteotomy, at the metatarsal, then we're going to end up with the S-shaped deformity. Okay, we don't want that. If we do an osteotomy much proximal, then again we'll end up with an S. So we have to know what is the apex of the deformity to plan our osteotomy accordingly. Now, these are measurements that are done. The most important one is probably is the tailor first metatarsal. So the long axis of the talus versus the long axis of first metatarsal. How do we identify the first metatarsal? This line represents the second metatarsal and the intermediate cuneiform articulation. And the one just distal to that is the first metatarsal, which is broader. Okay, this from here, this is the plantar surface of the first metatarsal, uh, and that is the dorsal surface. So that is the first metatarsal. It's shorter than the second one. Okay, so that is the angle of the inclination of the first metatarsal. So this is the Mary's angle. And the other calcaneal pitch is something again that we need to note. Now, those patients in which the heel is supposed to be prominent on the from behind, uh, but when there is an excessive calcaneus deformity, then the heel prominence also becomes, less prominent when the patient is weight bearing. Then there's the first metatarsal calcaneal angle to compare these. So these give you an idea of the relationship between the hindfoot and the forefoot. This X-ray, which is the AP weight-bearing X-ray, also called hindfoot alignment view, can see what is happening. The medial displacement of the calcaneus is resulting in tilting of the talus with the mortise and causing arthritis over the medial aspect of the ankle joint. So this is what we want to prevent. Now, Saltzman view is the name for the view, and Saltzman has two different views. The one that I am talking about, which is this one, that is done with a plate in front foot vertically. So the patient has to stand on a radiolucent box for that. And this is the normal alignment, and this is an abnormal alignment. We can see how much varusting is there. So these are essential for assessing the severity of the varus and where the deformity is, and then you plan your management. Now, many well with orthotics. So orthotics are basically the mainstay. Sorry, I haven't mentioned that here for most of the patients. But generally, these orthotics are lifelong. Of these deformities is neurogenic. So cavus foot, you see, more than 95% of the times the reason is neurogenic, and most common cause is Charcot-Marie tooth disease. So Charcot-Marie tooth disease is a hereditary motor neuropathy. It is hereditary, so there's no treatment for it. And it is various. It is of several different types, and each of them has varying severity, variable age of onset. Right now, we're talking about adult cavovarus deformity. So these patients who present to us in adulthood, their disease may have started way back in childhood, but usually they become symptomatic much later. So they become symptomatic because they start to get pain, or they start to get arthritis, which is also associated with pain, or they may start to get ulcerations due to the overloading over the callosities. So those things need to be managed. So much of this can be done with proper orthotic support, which is a little bit hard to get here in Pakistan. But orthotist, if you get a good orthotist, then he can manage a lot of the concerns. The problems get resolved with proper orthotic footwear. Now, orthotics have to be either accommodative or corrective. As I said, if you have found that the hind foot is correctable, then you would want to give a corrective orthotic, which means that to be designed in such a way that the abnormal angulation, abnormal inclination of the foot gets corrected. While if the hind foot is fixed, then if you give a corrective orthotic, that would actually increase the pressure over the points. That is not what you want. So that is another important reason why you need to know flexibility of the foot. So those patients who have had a trial of these orthotics and still it has not relieved the symptoms, or we can think of osteotomies. Osteotomies is one thing which is on the bones. Then there are tendon transfers muscles and tendons, and the Achilles tendon lengthening is a very important component of overall management. Now, with fixed deformities, uh, triple arthrodesis is a very good procedure where we can do, there are different types of triple arthrodesis procedures available. Uh, you can do uh, you can do a subtalar arthrodesis along with calcaneocuboid and calcaneocuboid and talonavicular fusion. You can also do a lambda nudi type of procedure. Uh, so it depends on the severity of the deformity. So this is going to, because you will be taking out a wedge, which means a lateral based medial apex wedge, then that is going to correct the hindfoot, the calcaneus deformity also. When you don't have a fixed hindfoot deformity, then you would not want to do a triple arthrodesis. You would want to do, not this, you would want to do a calcaneal osteotomy. Um, yeah, here it is being shown, calcaneal osteotomy, which would be a lateral slide osteotomy. There are many different procedures described for achieving a lateral slide. So that would neutralize the position of the hind foot and bring this part of the heel more in line with the axis of the tibia. Okay. Now that for the sorry, and then and with the apex of the deformity is more in the midfoot, which means at the naviculo-cuneiform junction. Then you would want to do something like a colostomy. These are diagrams which are showing guide pin insertions and showing what cuts you are going to make, and then you take out this wedge and fuse them, and that will give you a correction of the midfoot, the cavus deformity of the midfoot. When you have a more distal curve, like we saw in the other one, yeah, if we see that the apex is over this area, then the tarsal, the one where the apex lies, then you would want to do a first metatarsal or multiple metatarsal wedge osteotomies. Right. So here is an example. This patient had this is the apex. So for this apex of deformity, a metatarsal, basal metatarsal osteotomy was done, and for the heel varus, lateral slide was performed. So in this patient, a cold type of osteotomy was done here, and that has been fixed with a plate. Right. Then they have tendon procedures, such as tibialis posterior transfer, peroneus longus to brevis transfer, and some other transfers used for the clotos, like FDL transfer. So tibialis posterior is a mainstay because it is one of the strong tendons in these patients. These patients often have, the ones with Charcot-Marie tooth, often have weakness of peronei. So the peroneal tendons are overpowered by the inverting forces of the tibialis posterior. So this tibialis posterior is a deforming force. So when it is transferred anteriorly to the midfoot, like the intermediate cuneiform, and sometimes it can even be also transferred to the cuboid. If there is a gross weakness of the peronei, then it can even be transferred to the cuboid. Otherwise, mostly it is transferred to the middle cuneiform. That gives not only the correction of the inversion, dynamic inversion, but also gives a dorsiflexion force. Peroneus longus to brevis. Now, what is bringing the first metatarsal down? The dynamic force which is flexing the first metatarsal is the peroneus longus. Now, that can be sutured to the brevis and disconnected distally. So that is called a peroneus longus to brevis transfer. That will take care of the dynamic cavus, and also assist the brevis in its eversion action. Now, those patients who have clotos, in them several different procedures can be done. One of them is the flexor digitorum longus transfer to the dorsum. Girdlestone Taylor procedure is the one that I prefer, and that will take care of clotos. The idea is that you get the heel corrected by the calcaneal osteotomies, you get the midfoot corrected by the midfoot osteotomies, tendon transfers for the dynamic imbalance, and then you go to the forefoot also, and don't ignore the deformity in the toes. Sometimes correcting the midfoot and the hindfoot itself relieves, balances the muscle tension, so the toe deformity becomes very supple. In that case, you don't need to do anything further for the toes. Otherwise, you can add these transfers for that. So here's an overview. Patient with the cavo-varus alignment. Start with non-operative management, and then those who have mild deformity, which is forefoot driven, which means that the Coleman block test is able to correct it. Then you do one of these osteotomies. While if it is the hindfoot driven, then you do calcaneal osteotomy also. Okay. And when you have an advanced deformity as well as arthritis, then you try to first identify where is the apex. If the apex is more posterior, then you do a triple arthrodesis and a beak arthrodesis with the procedure the type it showed before. And then the anterior, if there's an anterior apex, then the cole osteotomy or a Japas osteotomy. Japas was the midfoot osteotomy that we talked about. Soft tissue posterior tibial lengthening. This is transfer and previous lengthening and transfer. Jones transfer can also be done. And is, as I said, the lengthening of the gastrocnemius is part of the procedure. Plantar fascia can be released if you find that during osteotomy of the midfoot, the plantar structures are very tight, then the plantar fascia can be released. You can do a partial medial plantar fasciectomy, or even a complete one can be done without any significant problems. If the ankle has been in varus for a long time, then the ankle lateral collateral ligament might need to be reconstructed. And when we are correcting the varus into neutral alignment, then the medial structures could become tight. Tarsal tunnel release is often added to it to prevent tarsal tunnel syndrome. So that's it from my side. This is the result that you expect. Pretty normal looking foot after the procedure. Maybe not 100%, but yeah, reasonable compared to what it was originally. This is the other side, which was the same as this side.
If that's okay, can I summarize for the exam part of in the exam, gait is important. If you are shown a case with foot deformity and it's not a table, it's a clinical examination, or even if it's a table, whatever, you must always start with gait. And the importance of the gait is that there are three things that have to touch. There is the big toe, the little toe, and the heel. It's called a tripod gait. Now, if you have a tripod gait, then you're nearly normal. If you don't have a tripod gait, then you're not normal. And if you're not normal, then you have to see whether it's flexible or not flexible. Now, if it's you do the Coleman block test, and if it's flexible, then you can do various corrective soft tissue methods or orthotics or various other things. If it's not correctable, then you point and enter the world of doing arthrodesis and osteotomies. And as Tashvin Saab said, if you are not correctable and you try to do orthotics, you will end up getting more pain. That's the summary of all foot examination that you will have in the exam. If you master that bit, you have no problems answering any questions. What Tashvin Saab has said is how to individualize each and every bit and make sure that you are correcting the right deformity rather than just correcting for the sake of correcting it. So if everybody is happy with that, it's time to have some questions, and then we can move on to Rizwan Saab, who's going to do a flat feet. Any questions for Tashvin Saab?
Yes, sir. I have one question. Can I ask?
Yeah, of course. Yeah, go ahead.
Go ahead.
Assalamualaikum, sir. Thank you, sir, for your talk. I wanted to just ask about the deformity, which is flexible and it is hindfoot driven. So can the isolated soft tissue procedure will be enough, or is it has to be associated with osteotomy? Or the isolated soft tissue procedures can lead to the complete resolution or correction of the deformity, that is flexible deformity?
Well, you see, which soft tissue procedure can balance the hindfoot? When you release the gastrocnemius, that will correct equinus, and that does result in some improvement in the varus deformity, but it does not really take care of all of it unless it's very mild. it's very mild, then you hardly need to think about doing surgery for that. So generally, lateral calcaneal slide is required when it is hindfoot driven.
Okay.
Any more questions? Or should we
Has
move?
to be associated with, so soft tissue procedure has to be associated with osteotomy, or if it is rigid, then it will lead to, we will need arthrodesis. But if it is a flexible deformity, it has to be associated with bony procedure. Isolated soft tissue will not work. That's what.
Yes, yes.
So there is a cheat code.
It is
Everything
required
has
to
got a cheat code.
correct the axis. If you don't correct the axis, any soft tissue procedure is going to fail.
Yeah, there is a cheat code. If you put them in an orthotics and make them walk, and you can correct that deformity and the pain goes away, then you can do some soft tissues. But unfortunately, patients, when they come to doctors and they come to exam as displaying, we will see that they will need more than just a soft tissue correction. But theoretically, it's possible, but practically, it is not.
Yeah.
Sir, what about tibialis anterior dysfunction?
Yes, tibialis anterior dysfunction is there in these patients because they often have equinus deformity. So that is what we try to compensate via tendon transfer, by transferring the tibialis posterior anteriorly.
Okay, sir, fine.
So should we welcome Rizwan Saab, and can you start your talk if you're ready, sir?
Yes, I will, because my laptop is a bit messy, so I'm doing with the mobile for the first time. I'm just sharing my screen. I've sent my link to Dr. Tashween as well.
Okay, so.
Shuzab, can you open it from your laptop? I'm not being able to find my file from mobile. I've sent you my Dropbox link as well.
You send my email?
Yeah. Tashween, at your AQL.
So while we're waiting to connect, a very simple question. When you talk about gait, what is the first phase of the gait? How do you describe the first phase of the gait? What do you call it? And why do we change terminology of the gait lately? All of you guys who are doing exams are more than welcome to answer. Just waiting for the slides to come up. Now, we used to call it something else. Now we call it initial contact. Do you know why? As part of the gait, nobody wants to have a chat. You cannot learn if you don't interact. Great point.
The first phase is the swing phase.
So listen to the question. The question is, why do we call it initial contact? And then push off, and then. Walaikum salam. No one wants to have a chat. Passive learners, Tashween Saab, they're all passive learners. In our part of the world, we have a hospital near to us, and it's called Oswestry. They have the highest pass percentage, and the reason for they have highest pass percentage is 6 months before the exam, the job of all the clinician is to humiliate them, basically ask questions on everything. By the time they come to the exam, they are so ready that they're asked. But if you don't participate, don't have an answer to a question, you will make that answer on the day of the exam, and sometimes that is very difficult. You have to have like a, pre-prepared answer for everything and just vomit out on the day of the exam. Did we find the email yet? Not yet.
Well, we're trying to sort this out. Let me share this screen if we want to discuss the gait cycle. So,
Dr. Ashwin, I have again share it with you. Your email address is ahmad, na?
yes.
Yeah, now it will be sent. Can you open it? I sent it to somebody else.
So guys, if you look at it, it says initial contact. It doesn't say heel strike. We used to call it heel strike. Now it says initial contact. Why is that? Can anybody explain to me why the terminology has changed? After a nice, very nice lecture from Tashwin Saab.
Sir, because it is initial contact is a part of heel strike.
So why don't we not call it heel strike? Why do we call it initial contact?
Sir, so it makes it more specific.
Is what, sorry?
It makes it more specific. Heel strike is a, you can say it's a broad term.
So when you look at all feet pathology, yeah, not every time you have a heel that will strike first. You don't have a tripod gait. So if you don't have a tripod gait, you don't have a gait if you call it heel strike first. Therefore, the modification is changed because whatever part of the foot strikes first, it is called initial contact. We're not waiting for the heel to strike, yeah? That's why the terminology has been changed. But you need to know your gait inside out when you're doing exams. You know, if you want to do hip, gait first. If you want to do knee, gait first. If you want to do foot and ankle, gait first. So what's a stable gait? Does anybody know what a stable gait is? So which is longer, a swing phase or a stance phase? You can see it here. I mean,
Stance phase, sir, is
so
longer.
why is the stance phase longer than a swing phase? What is the reason for that?
Because stability matters more than the walk. Then
Yes,
means
to get
movement.
from one place to the other, you have to be stable. And the most amount of time when your foot is on the ground, you're stable. That's why the stance phase is longer. When the stance phase becomes shorter and swing phase become longer, what happens then? It's because you're trying to run away from something. You're unstable, but you are quicker. As I said, you need to understand these prepositions of where the initial gait is, what is required to get to the initial contact, what you need to have, what muscles working for loading response, you know, what needs to lock when you're in the stance phase, how do you prepare for your swing phase, yeah? You're very lucky, guys, that the exam has been postponed indefinitely. Otherwise, it'll be very difficult because you guys don't want to participate. If you don't talk, you don't learn. That's my theory anyway.
Dr. Tashwin, did you get the link?
I'm just having. I can see the file now. I'm just it's downloading on my computer.
Thank you.
I didn't have
so
Dropbox
there is a
installed
very
on my computer.
scary analysis from these guys who predicted what was going to happen in England in COVID virus times. And they are saying by August, Pakistan is going to have more than 100,000 dead. Is that prediction, do you guys think, correct?
So far, there haven't been that many deaths.
Well, they predicted England and America deaths very, very clearly and very, very correctly. Now they're saying is that there's going to be a resurgence in Pakistan. And by September, they're talking about 1.2 million dead.
Wow. Well, we
Let's
just
hope not.
hope it doesn't happen like that. We
Yeah,
can't.
let's hope not.
Just hope not. Right. So here is the talk, and let me share. Right, Dr. Ridwan.
Thank
Over
you.
to you.
Thank you, Dr. Tashween. Thank you. Assalamu alaikum. Can all of you hear me?
Yes, sir.
So
Yes, sir.
let's start. Sorry for the delay. So our feet are no more alike than our faces. So you have to treat your feet just as you treat your face. So flat foot is a very common problem affecting the pediatric adults and geriatrics, and the foot is usually malaligned. Next slide, Tashinda. There is displacement of the hindfoot bones, forcing a lowering of the natural arch of the foot. So here you can see that there is a normal foot and there is a flat foot because lowering of the natural arch of the foot. Next slide. So this is a very important and critical diagram you have to see. This is the medial side of the foot. Here you can see that there is the spring ligament which holds the talus, which prevents the plantar flexion of the talus. There is the interosseous talocalcaneal ligament which prevents the plantar flexion together with the plantar fascia of the calcaneus. And there are the long plantar ligaments which keep in touch the midfoot. So, and most importantly, there is the medial arch stabilizers, the dynamic stabilizer in the form of tibialis posterior. When one of this function is lost, you will have flat feet. Next. So why tibialis posterior ruptures and is a problem rather than postperoneus longus or brevis? So there is a 14 millimeter zone of ischemia due to lack of mesotenon, and there is an acute curve. Most of you have fixed medial malleolus. You can see that the tibialis posterior curves behind the medial malleoli, and it has got a very shallow groove. And there is chances of compression underneath the flexor retinaculum. Next. So tibialis posterior pathophysiology is like repeated microtrauma leading to tendon sheath inflammation, tendon elongation, and finally tendon rupture. Next. So the pathology, once the tibialis posterior is ruptured, the medial restraints usually fails, and we have got flat feet. And there is no locking of the joints, and the unopposed pull of the peroneus brevis result in heel valgus. Next. So this is a good thing. These are normal. Here you can see that in a normal foot, all the restrainers are working, and the Meary's angle should be 0, which is the angle between the long axis of the talus and the first metatarsal. Next. Dr. Tashin, next करिएगा. There's some issue with Dr. Tashween's internet, I guess.
It'll come back, no worries. So while we're waiting, guys, when you do the exam, first of all is you do the gait, right? Then you have to work like a detective or an actor. You need to stand behind the person and see which direction the heel is, and then go in the front of the person and see whether you have the peekaboo sign and all that kind of stuff, like as I said. And then you get onto your knees and you put your fingers under the arch, right? And then you pick the big toe. Is the arch flexible or not? Does he have a cavus foot? Does he have a flat foot? And if he has got a flat foot, in the exam, what you can ask for is ask the person to wet his feet and stand on the floor. And you can have that nice picture that Rizwan showed you, you know, with the big toe and the foot. These are things that are expected from our trainees in the exam here. I'm not sure what the standard of your exam is, but by doing all these things, you can tell the examiner you know what you're doing and why you're examining it and what you're looking for. So it is important that your examination is like a professional, and it is like you've done something all the time, not just doing it for the first time in the exam.
Yeah, I guess he's
I'm
back.
sorry.
Two
I
one
had
two
some
sign.
internet issues. Sorry.
So whenever we are putting weight, so the calcaneum is also plantar flexing. And here you can see that the plantar fascia, the role of plantar fascia is very important. It works by the principle of windlass mechanism. It prevents the plantar flexion of the calcaneus. Next. Yeah, and the navicular and cuneiform also dorsiflexes, evert and abduct, and that is limited by the normal tibialis posterior. Next, please. And the metatarsal also dorsiflex and abduct, this is all normal. And this is the final picture when you get on a weight bearing view when all the restraints are working normally. And this what happens when one of those fails. For example, if there is a weak spring ligament or the talus calcaneal ligament, so the talus usually ends up. At the same time, the calcaneus also plantar flex and goes into valgus. And the midfoot and metatarsals usually dorsiflex and abduct, giving the shape of flat feet. Next. So there are three types of flat feet: the flexible one, the semi-flexible, and the rigid. Next. So the flexible is one when on non-weight bearing views there is an arch, and once you put on the weight, there is no arch, and the arch suddenly collapses. But it usually comes to normal when the patient standing position. Next. There isn't much of an arch with or without the pressure on the foot. In resting or whatever weight bearing, there is no arch. And the foot flattens out more during the standing and cannot come to normal position when standing. Next. And rigid is the one where the deformity is permanent, whether it's off the ground or on the ground. Next. So there is a misconception all over, particularly in our part of the world, that flat feet hai to kya hua? There is no, who cares? What difference does this make? So few slides about it. So alignment and function of our feet is very important in our day-to-day life. And when the feet are aligned, they work as a good unit. There is no excessive strains to the bone, ligaments, tendon, muscles, as well as neurovascular structures. Next. When the foot is poorly aligned, it will affect the weakest link of the chain, and it is a sign that something is wrong. You know that approximately in a normal individual takes around 6,000 to 10,000 steps a day. So you are loading this joint too much. Next. So due to the chronic nature of this disease, walking is the second most conscious function of our body. The individual finally realizes the more active I am, the more worse the pain, and the less the active, the pain is not so bad. Next. So what we do in our part, particularly, we decrease our activity. Game khel rahe honge, so we will not play games. We will not go to work. At the same time, we will start putting up on weight, then end up in hypercholesteremia, diabetes, and all the other stuff. Next. So, but the patient will still say, my feet are not properly positioned, but they are not bothering me at all. So we should tell the patient, are you sure about it? Next. So imagine our foot acting like raise the tire on the car without balancing the tire will function the great. Who cares? Next slide. So this will happen. Later, sooner or later, this kind of thing will happen. Not only the tire is affected, but the steering also becomes malaligned. Next So this is very important concept. So there are certain stages of flat foot deformity as described by Johnson, was further modified by Dr. Meyerson. The stage 1 is no deformity. Stage 2 is moderate flexible deformity, where the hind foot is most commonly involved. 2B is severe flexible flat foot deformity, where the forefoot abduction is too much. Stage 3 is fixed deformity, particularly the triple joint complex. 4A is hind foot valgus and flexible ankle. And stage 4B is when all the 4 joints are stiff and are degenerative. So all our discussion will be based on these stages. So as Dr. Munawar was saying, you have to look behind the patient. You have to make the patient stand up whenever you are doing a foot or ankle examination. You have to have weight-bearing X-rays. Here, anybody can appreciate a peekaboo sign, too many toes sign, and swelling and other stuff on the. Here you can see the significant heel valgus can easily be appreciated, and too many toe sign can also be appreciated with swelling over the medial side. Next. So there are certain radiographs. So on AP radiographs, weight-bearing AP, you have to make this thing important thing that the X-ray should be weight-bearing. So you see the talus first metatarsal angle, and also you see the talonavicular coverage. Normally should be less than 30 degree, and if there is more than 30 degree of uncoverage, you might need a lateral sided procedure, which I will be discussing later on. Next. So this is the lateral view. You can see the, which I have already shown you, the first talus first metatarsal angle, which should be around 20 to 25 degrees. And later stages in stage 3 and 4, you can be seeing arthritis. Next. So so you have to check for talar tilt, where in advanced stages, most of these patients comes with a talar tilt because the deltoid complex is insufficient. MRI usually is not very important, but it may help us in identifying the level of articular damage, so that we can choose between the reconstructive versus arthrodesis. Next. So these are some axes. You can see that on the lateral Neary's angle, down is the calcaneal pitch. This is important from the exam point of view. You can have a small paper. If I am making the exam, I will definitely put these to draw normal lines. Next. So this is the Dr. Tashni discussed about the Salzman view and the AP for talocalcaneal angle, which is the Kite's angle. All are weight bearing. Nothing is non-weight bearing. Next. So this is forefoot abduction, the talonavicular uncoverage. As you can see, that it should be in line with the first metatarsal. And if the exposure is more than 30%, so you have to do a lateral sided procedure. Next. So this is the CYME line, SIMA line. So on the right of your screen, you can see that the line is distorted. On the left is okay. So what are the management options? All the flat feet, about 90% of the flat feet usually respond to conservative management, and surgical options should be only limited to those patients who have failed a proper conservative trial. Next. So stage 1 is usually conservative, and the purpose is to prevent tendon rupture by giving rest to the tendon. Stage 2 is conservative for at least 6 months and to prevent progression of this disease. So there are various, stage 3 is patients with comorbid condition and unfit for surgery. We usually ask the patient to accommodate to live with the deformity. Next. So there are various conservative modalities available, like NSAIDs, management of this, for example, rheumatoid arthritis, if there is, so you can control the systemic disease, physical therapy, cryotherapy, activity modifications, orthotics, medial wedge, medial column, UCBL, boot, heel alterations, various modalities are available. Next. So this is an example of certain exercises. One is the calf stretching exercises, single leg standing exercises, the tibialis posterior strengthening exercises. Next. These are the various braces, the medial arch suppose, different kind of AFOs are available. Next. It is a simple way you can make a mold. The medial arch support can easily be made in the clinic as well, but it has to be soft, otherwise ulceration could be present on pressure points. Next. This is a patient wearing a medial arch support. Next, please. So, as I've already told you that conservative therapy usually does this purpose in about 70 to 80% of the patient, and only 20% of the patient, or less than 20, are those who will require surgical intervention. Next. So, symptomatic patients not controlled by conservative treatment, clear progression of pathology and duration of conservative treatment is debatable. Some says for 1 year, some says for 2 years, but still debatable. These are the few surgical indications. Next. So Dr. Arif asked a question, flexible deformity में soft tissue procedures. So mostly this is a combination of soft tissue plus bony. So it is tendon repair, lengthening, osteotomies, arthrodesis. It's a combination. It's an a la carte. Basically, you have to pick and choose for different patients. No, all patients are not the same. So soft tissue, if stage 2 or late 1, you can do debridement. You can do tendinosis with the FDL. You can just straighten a sort of a Kidner procedure can be done. Next. So if the peroneus, the tibialis posterior tendon is too much elongated or ruptured, so you have to do a FDL transfer. This is the most expendable of all the flexors. You can do an say that FDL usually works very well because they are in-phase tendons. So with the advent of modern science, so we have got internal brace available in Pakistan with spring ligament with that fiber tape. So, but soft tissue procedures alone are usually not the only option. It will usually end up in a failure. Next. So always remember, whenever you are dealing with foot and ankle, tendon-Achilles has to be assessed. Once you correct the alignment, you definitely will have an equinus deformity because of the tight tendon-Achilles. So you can do a 3 percutaneous tendon-Achilles lengthening, and in some cases you can also do a Welpius type of a procedure as well. Next. So here you can see that when the ankle was dorsiflexed, it was about 4 to 5 centimeter of length of gastrocnemius. So next करिएगा. So you can see that distance. So next. So here you can see that only soft tissue will fail. So assist adequate mechanical control of deforming forces. ये आप अपना वो मैंने एक एनिमेशन डाली हुई एरो पे नजर रखिएगा कि हील वाल्गस में है. सर नेक्स्ट करिएगा. So now it is straight. Then later. Next करिएगा. So once you correct the heel valgus, so it will, as you know, the tendon-Achilles is the strongest tendon in the body, and it has to be around 2-3 degree valgus. But if it is more, so then it is not only exerting a everting force, but is also preventing flexion. So you have to make it an inverter rather than an everter. So it has to move medially. So it improves the mechanical access of the lower limb. Next. So here you can see that only a small medial calcaneal osteotomy corrects the heel valgus and can be fixed with 2 screws, 1 screws, step plate, whatever you like. Next. So stage 2A, I usually prefer medializing calcaneal osteotomy plus FDL transfer plus tendo-Achilles lengthening. So you have got two soft tissue procedure combined with a bony procedure. Usually the patient is kept in a back slab for about 2 weeks, walks with a boot in about 6 weeks, and can be allowed weight bearing once healing is achieved. So for stage 2B, so in addition to medial calcaneal osteotomy and transfer, so there is basically more. As you know, that 2B means that the forefoot abduction is too much. So you go on the lateral side, either you do arthrodesis, distract the joint, or you do an evans, or you lengthen the lateral column. And same post-op rehabilitation protocol is followed. For stage, so next career. So some say 10 mm of calcaneocoboid joint is open and a graft is just placed. You can either leave the graft or you can put in a screw. Here is the slide which shows that the forefoot abduction can easily be corrected with this calcaneocoboid arthrodesis or lateral evans osteotomy. Next. So next करिएगा एक मिनट इसके बाद हाँ. So as I was already telling you that midfoot abduction and some sort of supination is usually covered with the help of this lateral column lengthening and also the talonavicular coverage. Whether you will fix it with a K-wire or screws it up is up to you. Next, please. So Meyerson et al. Had a recently, not recently, a few years back published an article of about 129 patients who we operated in stage 2 and showed very good and promising results. Next. So for stage 3, when there is signs of subtalar arthritis and other joints arthritis, so most of the time is a common misnomer that always do a triple procedure. You have to save the calcaneocoboid joint. So the outcomes are better with a double fusion as compared for next. Here you can see that the fusion was done, subtalar arthrodesis was done. The same case, the triple arthrodesis was done here. So you can use a single incision, posterior-medial incision for doing the subtalar arthrodesis together with the talonavicular arthrodesis. It's a very simple procedure, but you have to keep in mind the various neurovascular structures. Next. So this is an incision from the medial side, a long incision, but you can easily expose the subtalar and the talonavicular via this approach. This is so for stage 4, when the ankle is also fixed, deformed, so the only option left is to have a pan-talar arthrodesis, which is a highly, it is associated with its own complication. So it could be, all options should be explained to the family and the patient. Next. So when the ankle is a bit mobile and there is evidence we can do, so you do a triple arthrodesis and you can supplement it with a total ankle replacement. But I haven't had any experience of total ankle replacement in Pakistan. So this is a very good algorithm. Last few slides, if there is a flexible deformity, you do an FDL transfer. If there dominant is hindfoot valgus, you go for a medial calcaneal osteotomy. And if there is forefoot abduction, you do a lateral column lengthening, either fusion or evans. And after doing this, you have to look for the tendon Achilles. Never ever leave the tendon Achilles. And for flexible, you can either do a double fusion, triple fusion, and you can do a Pan-talar in selective cases. And for forefoot supination or hypermobility of the forefoot, or so you have to do a medial column fusion as well. Next. So this is a summary for stage 1. You do conservative. Stage 2, I've already discussed. This is a take-home message for all of you. So what to do in which stage. Next. Soft tissue involvement to be considered properly managed and combined with bony procedures. Stage 1 में आप soft tissue कर सकते हैं. And osteotomy usually gets mechanical control of the peritalar joint complex. Next. Medium-term benefit of calcaneum osteotomy and FDR are very good. Arthrodesis also proved to be very good in patient with arthritis. To have the final function is to have a plantigrade painless foot. Next. So this is, I would like to thank, and this is the AKU foot and ankle service. So we were working on a tendo Achilles model to make our resident learn percutaneous mid-substance tendo Achilles repair, which was done by Dr. Tashmi. Thank you very much.
So very good. Yeah, I mean, the summary for all of you guys is that if you feel it's a soft tissue problem, give the person an orthotics and see how he responds to it. If you feel it's a fixed problem, don't do any arthrodesis unless you give the person a trial of putting it in a plaster, making them walk for a little while, a couple of weeks, and see how it responds. Most patients do not like arthrodesis, although we know surgically they do well. So, you know, don't just dish out operations. You need to know what you're doing and why you're doing. Don't learn one or two operations. You need to know the mechanics before you can give out options. There are various procedures for various type of problems. And talking about ankle replacement, in UK, we have now version 5 and version 6 of the implant, which means that it doesn't work. You know, if you have too many options and too many revisions of an implant, that implant must be not working properly. But yeah, some people do it. They're very brave. So question time, guys. Everybody is disappeared. No questions?
Assalamualaikum, sir. Thank you, Dr. Rizwan, for your talk. So I was just asking about the question of doing arthrodesis in the rigid deformity. So do you prefer doing the triple or sparing the calcaneocuboid joint?
Sorry, ideally it depends upon the level of, you have to do an MRI to see if the calcaneocuboid joint can be spared, you should spare it. So, but in our part of the world where the hospital treatment is borne by the patient himself or herself, so people usually say that ek hi go mein aap fix kar dein sab. So ideally double fusion should be done, and I prefer doing double fusion. And if the calcaneocuboid joint later becomes symptomatic, so we can fuse. It's a very small procedure.
And do you do the reconstruction of the spring ligament along with the triple arthrodesis?
Sometimes yes, because spring ligament is usually, I haven't seen a rupture. I have now quite a few cases for flat feet surgery. So the spring ligament is usually elongated, stretched out. So once you do a double breasting of the spring ligament, internal brace is a bit expensive. So you just double press the spring ligament, so it will serve the purpose, and then you have to transfer the FDL, which supports this. Fibrotic tissue can be achieved at the site where you do the double breasting.
Most of the talk was on adult acquired flat foot. I just wanted your opinion about if the patient, pediatric patient.
The pediatric patient will be a different talk. I've asked Batisa if he has time to do it, but today's adult deformities only.
Okay, thank you.
One question from pathomechanics of tibialis posterior tendon. Can I ask?
Yeah, we can hear you.
Hello.
Yeah, we can hear you. Ask your question.
Okay, sir. Sir, my question is, if a person is having unilateral posterior tibialis tendon insufficiency, why on tiptoe standing bilaterally, it is not visible? Why on single? Means on single leg stance, patient is able to or unable to, while if he is standing on the tiptoes, he cannot. What's the pathomechanics behind it? Can I clear my question?
The pathomechanics is very simple. There's more weight when you're doing it bilaterally. If you're doing it single, there's not enough weight. So that's possibly the reason. I don't know much about it. Maybe one of the Rizwan Saab or Tashin Saab can explain your answer. But the reason why you can't do it tip-top bilaterally is now you're using your good legs. You're putting too much weight.
If I understand, you're saying that when one side tibialis posterior is ruptured and you try to do a heel raise one ground, that patient is not going to be, one who has a tibialis posterior rupture will not be able to do heel lift when the other foot is off the ground. And when the other foot is on the ground, only then he will be able to do it. And even in that case, the heel will not go into varus. Normally, when you do a double heel lift, the heel goes into varus because of tibialis posterior. This patient who has a rupture will be getting the heel to go to varus. Does that answer your question?
So probably does, because apparently not in the system. Anyway, thank you guys. I am going to call it a day. Thank you very much, Ashwin Saab. Thank you very much, Rizwan Saab. Very, very informative. I'm not a foot and ankle surgeon, I must admit, but it's revised a lot of stuff for me, and I'm sure the guys would learn. But boys, if you are going to come to teaching, you must come prepared for answering and be interactive. Otherwise, there is no point in doing a teaching when you guys just want to come and listen to somebody talk. You never learn. Anyway, thank you, everybody. I'm going to put a video on the forum for everybody to have a look at it. But thank you again. Thank you, everybody. And hopefully we'll see you soon.
Thank you.
Inshallah.
Thank you, sir.
Thank you, Allah Hafiz. Thank you, Rizwan. Thank you, Dr. Manawar.
Thank you, sir.
And thank you, all the participants.